Imagine you are wrapping up a really grueling 12-hour shift on the wards. Your muscles are burning, your eyelids feel incredibly heavy, and, just holding your head up takes a conscious effort.
Yeah, and for most of us, that's just a clear sign to go to sleep.
Right, exactly. But what if that profound, paralyzing exhaustion wasn't from a long shift, but from your own immune system actively dismantling the connections between your nerves and your muscles day after day? We'll be breaking down all major concepts covered on the exam. I'm Harvey.
And I'm Donna. We are MCCQE reviewers, and our mission with this deep dive is to help Canadian medical students like you feel fully prepared, comfortable, and confident with the exam review process.
Absolutely.
But before jumping into the clinical details, I just need to give a brief disclaimer. This deep dive is for medical education purposes only, not medical advice. And all clinical decisions should obviously involve a qualified healthcare provider.
Perfect. So today we are targeting section S08 Neurology, and specifically we're looking at neuromuscular junction, or NMJ, diseases.
Neurology can definitely feel like a labyrinth on the MCCQE. I mean, you have localizations, intersecting pathways, overlapping symptoms. It is a lot.
It really is a lot. So to cut through the noise, we are basing today's teaching on a highly reliable StatPearls article dedicated entirely to myasthenia gravis, or MG. By the end of this deep dive, you will be able to spot the classic AG vignettes instantly because, well, you'll understand exactly how the disease behaves.
Understanding behavior is key here. Rote memorization of symptoms will really only get you so far on the boards.
Yeah, they love to test the why.
Exactly. To consistently beat the tricky vignettes, we need to look at the cellular battleground. We have to establish precisely what is failing at the neuromuscular junction.
Yeah.
So the clinical presentation actually makes logical sense.
Okay, let's unpack this. At a high level, myasthenia gravis is an autoimmune disorder, and the hallmark is fluctuating weakness. That weakness occurs because the body generates autoantibodies against specific postsynaptic membrane proteins at the junction. But, the MCCQE, they aren't going to let us off the hook with just a broad definition.
Definitely not.
We need to know the specific types of antibodies driving this process because they dictate the pathology.
They absolutely dictate the pathology, and this is exactly where the exam will test your depth of knowledge.
Yeah.
The most common driver, which is responsible for about 80 to 85% of cases, are autoantibodies against the nicotinic acetylcholine receptors.
You'll often see that written as NACHR antibodies.
Yes, exactly. And the critical detail here is their classification. They are IgG1 and IG3 subtypes.
And those specific subtypes are notorious, right?
Yeah.
Because they actively recruit the immune system's heavy artillery, the complement cascade.
Yeah, that complement activation is the primary destructive force here. It triggers the formation of the membrane attack complex, or MAC.
Which sounds exactly like what it does.
It really does. The MAC essentially drills microscopic pores directly into the postsynaptic membrane of the muscle. So it causes this profound physical degradation of the receptors. And on top of that, these antibodies cross-link the receptors, forcing the muscle cell to internalize and degrade them faster than they can even be replaced.
So if we look at the histopathology of the muscle tissue in these NACHR patients, we are going to see the aftermath of that destruction.
Oh, absolutely. You see massive atrophic changes. The synaptic clefts get widened and simplified. The postsynaptic folds, which usually give the junction this massive surface area to catch acetylcholine, they are just blunted or completely obliterated.
Wow.
Yeah, you will see prominent neurogenic atrophy. And the origin point for this whole assault usually traces back to the thymus.
The thymus is such a fascinating organ. Normally, it's supposed to involute and basically turn into fat as we reach adulthood. But in myasthenia gravis, it seems to go completely rogue.
It does.
The source material mentions epithelial hyperplasia and germinal centers. What does that actually look like mechanistically?
Well, instead of retiring, the thymus basically builds unauthorized immune boot camps. The epithelial cells overproliferate. That's the hyperplasia part. And the germinal centers mean the thymus has started hosting active B-cell follicles right inside its own tissue.
Oh, so it's manufacturing the threat.
Exactly. It turns into a central factory, aggressively training B-cells to produce these autoantibodies against the muscle proteins.
Let's use an analogy here just to lock this in. The NACHR antibodies are acting like a demolition crew. They are using the MAC to actively blow up the postsynaptic membrane, flattening the structural folds, destroying the receptors.
Right, a literal demolition.
But there is another distinct subset of patients on the exam who don't have these antibodies. They have antibodies against muscle-specific kinase, or LRP4.
The MuSK and LRP4 variants operate under completely different rules, and this is high yield. These antibodies are of the IgG4 subtype.
And IgG4 cannot activate the complement cascade, which means no membrane attack complex and no demolition crew.
Right. Without the M assay, they have to cause failure differently. These IgG4 antibodies bind to the agrin LRP4 MuSK protein complex. Under normal circumstances, that complex is the essential scaffolding of the junction.
It holds everything together.
Exactly. It forces all the acetylcholine receptors to tightly cluster together directly under the nerve terminal so they can efficiently catch the neurotransmitters.
Okay, so expanding on that earlier analogy, if the first group is a demolition crew physically destroying the site, these MuSK antibodies are more like stealing the blueprints.
Not like that.
Yeah, they dismantle the scaffolding. So the receptors are still there, but they drift apart. They can't properly cluster, which leads to a massive drop in transmission efficiency, bringing about muscle failure without direct destruction.
That is the perfect way to visualize the distinction. And because there is no direct MA demolition, the histopathology in a MuSK patient looks entirely different. You don't see that massive muscle atrophy.
What do you see instead?
Well, the muscle biopsies show severe mitochondrial abnormalities, giant, swollen, degenerating mitochondria due to all the chaotic metabolic stress. Furthermore, the thymus in MuSK patients is usually totally normal. It undergoes standard age-related involution.
Okay, so the cellular failure is clear. Whether the receptors are actively blown up by complement or just scattered because of a lack of scaffolding, the end result is a depleted postsynaptic receptor pool.
Exactly.
When the nerve fires, it dumps acetylcholine into the cleft, but there just aren't enough receptors to catch the signal and trigger an action potential. Which brings us directly to how this looks clinically.
Right. For the standard epidemiology on the boards, the prevalence sits around 20 per 100,000 in the U.S. But the key is the bimodal distribution. You are looking for a female predominance in patients under 40 years old and a male predominance in patients over 50.
And the cardinal symptom you are scanning the vignette for is fluctuating weakness. A patient might describe waking up feeling relatively normal, but as the day progresses or with sustained physical exertion, their muscles just give out.
And critically, a period of rest brings their strength back.
The physiology behind that rest period is crucial, right? Sustained muscle contraction depletes the presynaptic terminal's readily releasable pool of acetylcholine vesicles.
Yeah. In a healthy person, there are so many receptors that even a depleted release still triggers an action potential. But in an MG patient, with their limited receptor pool, that drop in acetylcholine output completely halts transmission. Resting gives the nerve time to repackage and restage new acetylcholine vesicles.
Got it. Now, in the vignette, the first muscle groups to fail are almost always the extraocular muscles. You'll see spitosis, the drooping eyelid, and diplopia, double vision.
Right, the eyes are classic.
After the eyes, it tends to hit the bulbar muscles. So a patient might complain of coughing while swallowing, a hoarse voice that gets whispery as they keep talking, or, extreme jaw fatigue halfway through eating a steak. And then finally, it descends to the proximal extremities.
During your physical exam, you obviously test for that fatigability by asking the patient to sustain an upward gaze for a minute to provoke the ptosis. But the negative findings here are just as high yield.
The normal stuff.
Right. The pupils will react perfectly normally to light. Deep tendon reflexes, or DTRs, will be brisk and intact. And the sensory exam will be completely flawless.
Wait, I need to push back on something here. Acetylcholine is the primary neurotransmitter for the entire parasympathetic nervous system. It controls bowel motility, bladder function, heart rate, sweating. If acetylcholine transmission is failing at the junction, why wouldn't this patient also present with severe autonomic dysfunction?
What's fascinating here is the sheer specificity of the autoantibodies.
Yeah.
Myasthenia gravis exclusively targets the nicotinic cholinergic receptors, which are unique to skeletal muscle.
Ah, I see.
Yeah, it completely ignores the muscarinic cholinergic receptors, which are the ones driving the autonomic nervous system. Since the heart, the bowel, and the bladder rely on muscarinic receptors, those autonomic functions remain entirely shielded from the autoimmune attack.
That distinction between nicotinic and muscarinic is definitely going to show up on test day. We also need to highlight a major exam trap regarding the presentation, the MuSK variant. We know the pathology is different, but how does the clinical picture change?
Well, the MuSK variant kind of flips the standard presentation on its head. It is more common in young females, but it frequently spares the extraocular muscles. Right, you won't see that classic drooping eyelid. Instead, it aggressively targets the bulbar, facial, and neck extensor muscles. Patients might present with a dropped head posture or severe respiratory distress. The risk for a rapid, life-threatening myasthenic crisis is significantly higher here.
Good to know. So if a vignette describes a young woman with profound neck weakness, difficulty chewing, and perfectly normal eye movements, MuSK-MG should immediately jump to the top of the differential.
Absolutely.
Now let's move into the diagnostic workup. You suspect MG based on the fluctuating weakness and the normal reflexes. How do you logically prove it for the exam?
The workup starts with a strict serology cascade. Step 1, check for anti-AChR antibodies. This is highly specific. If it's positive in the context of clinical weakness, you have your diagnosis.
But it's not perfect, right?
No, it captures about 80% of generalized MG patients, but only about 50% of those with pure ocular symptoms.
So if that initial panel comes back negative, you don't rule out the disease, you move to step 2.
Step 2 is checking for anti-MuSK antibodies. This will identify another 5 to 10% of the patient pool. Interestingly, patients almost never test positive for both AChR and MuSK antibodies simultaneously.
And if they are negative for both?
Then you check for anti-LRP4 antibodies. And it's also standard practice to run a panel for anti-striated muscle antibodies. While they show up in about 30% of MG patients generally, their real clinical value is acting as a highly sensitive marker for the presence of a thymoma, especially in younger demographics.
Here's where it gets really interesting. Serology can take days to process. If you need immediate answers on the ward, the classic bedside intervention is the edrophonium, or tensilon test.
Right, the tensilon test.
Edrophonium is an ultra-short-acting acetylcholinesterase inhibitor. By blocking the enzyme that breaks down acetylcholine in the cleft, you basically temporarily flood the junction with neurotransmitters. You inject it IV, and you can literally watch a patient's camptosis resolve within 30 seconds.
It's pretty amazing to see. The tensilon test has incredible sensitivity, particularly for pure ocular MG, where the blood work is often negative. But the exam will also heavily test your knowledge of alternative clinical tests, specifically the ice pack test.
Oh yeah, the ice pack.
You place a bag of ice over the drooping eyelid for 2 to 5 minutes, remove it, and observe if the ptosis improves.
Okay, I have to ask. If we have a pharmacological test like edrophonium that works in seconds, when and why would a physician actually reach for a bag of ice on the ward? It sounds a bit antiquated.
It sounds low-tech, I know, but it is rooted in pure physiology and patient safety. Edrophonium pushes systemic cholinergic levels up, which can cause severe bradycardia or bronchospasm.
Oh, that makes sense.
Yeah, so if a patient is elderly, has cardiac conduction issues, or has severe asthma, the tensilon test is strictly contraindicated. The ice pack is the alternative. Cooling the muscle tissue locally actually decreases the catalytic efficiency of acetylcholinesterase. By chilling the eyelid, you slow down the enzyme, naturally boosting acetylcholine in that localized cleft without risking the patient's heart rate.
That makes a lot of sense. Using temperature to manipulate the enzymes locally when systemic drugs are too dangerous. What about electrophysiology?
You rely on repetitive nerve stimulation, or RNS, and single-fiber EMG, or SFMG. They are crucial for seronegative patients.
Can you break down what single-fiber EMG actually measures? Because that phrase gets thrown around, but it can be hard to conceptualize.
Sure. Normally when a nerve fires, all the individual muscle fibers within that specific motor unit contract in almost perfect unison. With single-fiber EMG, you place a microscopic needle into the muscle to record the electrical firing of 2 adjacent fibers with the exact same nerve.
Okay, so you're comparing the timing.
Exactly. In myasthenia gravis, because the receptors are depleted and scattered, it takes some fibers a fraction of a millisecond longer to reach the electrical threshold for contraction. That microscopic delay and variability between the 2 fibers is called jitter. High jitter is the electrophysiological hallmark of an unstable neuromuscular junction.
Great explanation. Once you confirm the diagnosis with serology or EMG, imaging is the mandatory next step. Every newly diagnosed patient must get a CT or MRI of the chest.
You are scanning to rule out a thymoma, which is present in roughly 10% of MG patients. Identifying a thymic tumor fundamentally alters the surgical management plan. You also need to run baseline lab work for TSH, rheumatoid factor, and ANA because autoimmune disorders love to travel in packs.
Always check the thyroid. With the diagnosis locked in, we have to talk management. The goal is to restore muscle function and prevent a life-threatening respiratory crisis.
First-line symptomatic treatment relies on oral acetylcholinesterase inhibitors. Pyridostigmine is the gold standard because it has a longer half-life than older drugs like neostigmine. It provides steadier symptom relief throughout the day.
What if they can't tolerate it?
If a patient experiences severe gastrointestinal intolerance to the bromide component of pyridostigmine, ambinonium chloride is the designated backup.
But recall our trap regarding the MuSK variant. Patients with MuSK-MG often show a notoriously poor clinical response to these cholinesterase inhibitors.
They do, and it ties back to the pathology. Flooding the junction with extra acetylcholine doesn't help much if the core problem is a complete lack of structural scaffolding holding the receptors in place. For those patients, or anyone failing pyridostigmine, you really must step up to immunosuppression.
The first line there includes glucocorticoids like prednisone and azathioprine. Azathioprine is a purine analog that halts DNA replication, effectively starving the rapidly dividing T and B cells and shutting down autoantibody production.
Right. And if those failed, the second-line options include cyclosporine, methotrexate, mycophenolate, or tacrolimus.
Now, when a patient is crashing, you need rapid intervention. Intravenous immunoglobulin, IVIG, or plasmapheresis are the heavy hitters. They don't just suppress the immune system, they actively neutralize or filter out the circulating autoantibodies from the blood.
Yeah, you deploy those during a severe crisis or to rapidly stabilize a patient right before surgery.
Let's focus on surgery. Thymectomy indications are incredibly high yield for the MCCQE.
The rules for thymectomy are rigid. Rule 1, if a thymoma is present, the thymus comes out, regardless of age or symptoms.
Makes sense.
Rule 2, in the absence of a tumor, a thymectomy is still indicated for patients with generalized ACH-positive myasthenia gravis who are between the ages of 18 and 50.
And what's the trap there?
You do not perform a thymectomy for purely ocular MG, and you do not perform it for non-thymomatous MuSK-MG. Remember, the thymus in MuSK patients doesn't show that hyperplastic germinal center pathology. Removing a normal thymus won't change the course of their disease.
Good to keep in mind. The final piece of management is preventing a crisis. Patient education is vital here. Stress, heat, and infections can precipitate profound weakness, but the board examiners love testing iatrogenic crises. We need to know which specific drug classes will throw a stable MG patient into respiratory failure.
The major offenders are aminoglycosides, fluoroquinolones, beta blockers, and neuromuscular blocking agents.
Let's explain why. Taking aminoglycosides like gentamicin is a disaster for these patients because the drug actually blocks presynaptic calcium channels. Less calcium entering the nerve means fewer acetylcholine vesicles get released.
Yeah, and if you already have a depleted receptor pool, dropping the acetylcholine release is enough to completely halt muscle contraction.
Fluoroquinolones are just as dangerous, but they act postsynaptically, directly blocking the acetylcholine receptor channel itself. Beta blockers can also interfere with neuromuscular transmission. Prescribing any of these to an MG patient can rapidly induce a crisis.
Which sets up a very frightening clinical scenario for the exam.
It really does. Imagine a patient with known myasthenia gravis is wheeled into the ER in acute respiratory distress. They are paralyzed and struggling to breathe. How do you confidently differentiate between a myasthenic crisis caused by an infection or one of those antibiotics and a cholinergic crisis? Both cause profound weakness.
If we connect this to the bigger picture, the distinction becomes obvious. A cholinergic crisis is an iatrogenic overdose.
Yeah.
The patient took way too much pyridostigmine. Their system is completely flooded with acetylcholine.
Right.
That massive surplus overstimulates the nicotinic receptors, causing depolarization, block, and weakness. But more importantly, all that excess acetylcholine spills over and floods the muscarinic receptors in the autonomic system.
So the autonomic shield is broken. This is where you see the massive parasympathetic overdrive.
Precisely. You will see extreme SLU-DGE symptoms: salivation, lacrimation, urination, defecation, GI cramping, and emesis. The patient will be sweating profusely, their pupils will be constricted, they will have severe diarrhea, and their muscles will be actively fasciculating or twitching from the overstimulation.
Wow, okay. A myasthenic crisis, by contrast, is just the disease worsening. The receptors are blocked or destroyed. There is no muscarinic spillover. The patient will have profound respiratory weakness, but they will be completely dry. No extreme sweating, no diarrhea, no constricted pupils. So if the patient is wet, twitchy, and weak, it's a cholinergic crisis. If they are dry and paralyzed, it's myasthenic.
That distinction will save you on the wards and on the boards.
So what does this all mean? Let's distill this deep dive into 3 rapid-fire MCCQE takeaways for the listener. Number 1, fluctuating weakness that spares pupils and DTRs. Number 2, the pathophysiological difference in presentation and thymus involvement between AChR and MuSK antibodies. And number 3, the specific antibiotic classes to avoid, like aminoglycosides and fluoroquinolones.
Before we wrap up, there is a lingering mystery from the StatPearls text worth considering. We noted that childhood myasthenia gravis is relatively rare in Western populations. However, in Asian countries, it accounts for a staggering 50% of all MG patients under the age of 15, usually presenting almost exclusively with extraocular weakness.
50%. That is a massive geographic divergence.
It raises a profound question. What unknown genetic vulnerabilities or hyperspecific environmental triggers are driving this massive epidemiological shift in pediatric autoimmunity? It highlights how much we still have to learn about the intersection of genetics and immune dysregulation. It is a really compelling area of ongoing neurological research to keep an eye on.
A great reminder that the science is never settled. Keep reviewing, trust your clinical reasoning, and we will see you on the next deep dive.